and currently he is working as the director of Health Village Hospital of Bhubaneswar, and he has keen interest in pain management system as well as also the palliative care medicine. And he has a number of publications. He has book chapters on pain management, and he has also done certificate courses in essentials of palliative care, fellowship on regional anesthesia, and training on advanced interventional pain management. And he is also uh, has done his IAPM in 2019. He is one of the known pain physician in Odisha. Many times we invite him also in our institute for demonstrating certain procedures, and in long rounds we'll have also we'll continue to have association with Professor Dr. Shovan. He is currently working as a professor there at High Tech Medical College, Bhubaneswar. Without much wasting time, let us invite Professor Dr. Shovan, and over to you. Thank you.
Thank you for the nice introduction, sir. First of all, I'm really sorry for the delay. Actually, in the last moment, my laptop got crashed, and unfortunately, the preparation that I had done for this meeting today, I couldn't revive because I haven't saved it in my Google. And that's why the one that I had saved earlier in my almost I'll be presenting the same overall view, the overview of interventional pain management and the aspects that we go through, and that are the procedures that we usually do. And more or less, I'll be discussing more of low back pain. But along with that, as the presentation is for the overall interventional pain management, I'll be touching some parts little bit from every aspect of the pain management. So I'll try to give an overview, and let me share my screen.
Just 1 minute. Sorry to intervene you. That can you focus something about how to select the cases for
yes,
different
sir,
forms of?
Yes, sir. We'll be discussing on. I just want to be to do it more or less on an interactive session rather than I'll be telling on because everybody knows about the theory. I'll not be telling something new that I'll be just in a brief. I'll try to finish up in between 10-15 minutes. What are the procedures to be done? And then we will discuss on the clinical part, how to choose the patients, what are the symptoms from which we can know that these are the patients who are to be selected for procedures, and what are the particular procedures to be done. So that will be better. So if you can allow me to share the screen, I'll do
yes, please go ahead. Please go ahead.
Sir, actually, the host has disabled the participant screen sharing. So if you can allow me.
He will enable you now. Amit, please enable him. Amit, hello?
Yes, sir.
Please.
So he's already given co-host, right, sir?
You can share your screen, Dr. Shovan.
No, I'm not able to. Actually, I have joined from from my laptop as well as from my phone, because the laptop doesn't have a webcam. Sorry, laptop, the desktop doesn't have a webcam. That is why if you can allow the other one. I think there are 2 participants will be shown. Shovan.
Yes, sir. I have given the permission for the other one also, sir.
My request to all the participants, please come forward and you can clear your doubt. As you said that it will be more of clinical rather than theoretical. So please come forward. You can ask your questions to Dr. Rath.
Okay, I think I'm visible now.
Yes, you are visible. You are visible. Please go ahead. Yes, please go ahead.
Yeah, should I start now?
Yes, please. You can start.
Okay, as sir has already told, I'm actually the director as well as I'm a consultant pain palliative care physician working at the Health Village Hospital. This is basically my own hospital where I'm doing almost for last 7 or 8 years. I'm doing also chronic pain practices. So this is the hospital that we have. Now, the services that we provide is in the name of pain-free services or pain-free Odisha. The motive was started in 2010 to make Odisha pain-free. Now, everything will take back your life. So, if we compare the different kinds of diseases that we come across, basically our focus is more or less for the diseases that are life-threatening, like diabetes, hypertension, stroke, and cancer, whereas the percentage of cases prevalent in migraine, discogenic pain, or musculoskeletal pain and knee pain are more, but our focus is less because of the severity that we face usually during the course of the disease. Now, despite the magnitude of suffering, the chronic neuropathic pain remains grossly undertreated in most of the patients. The reason for this are basically three. The first one is the low priority of pain relief among the patients, among the healthcare system, because what we have seen is, particularly if the patient is admitted in the hospital for some cause and there is some kind of pain, we neglect the pain the maximum and we look after the other parameters which are we think that more life threatening, like diabetes, cardiac illness and other illnesses. Lack of knowledge among both healthcare professionals as well as from the consumers, and exaggerated fears of using opioids or other drugs in a proper dosing. Particularly the patients, you must have seen that people usually ask, if I am taking too much of a NSAIDs or too much of painkillers, is going to harm my kidney and other systems, so I won't be taking the drugs. That is what we can say, exaggerated fears of opioids and other drugs and their side effects. So that is why the concept of pain clinic started, just to maintain two things. Number one, to get a proper diagnosis of the disease and to get the proper treatment, proper medication, proper dose of medication, proper duration of medication, and if necessary, where to refer the patient. If not, what are the interventions that can be done. That is why the pain clinic started. And there are various diseases that we cover in this pain clinic, starting from headache, migraine, then neck pain, spondylitis, very common, low back pain, which is the topic of discussions of today, then sciatica or radiculitis, radiating pain from the lower back, osteoarthritis, knee pain, and various other kinds of knee pain, trigeminal neuralgia, post-herpetic neuralgia, fibromyalgia, and the next is cancer-related pain, neuropathic pain, and labor pain. Though we'll not be discussing in detail about these things. Now, what is extra in pain clinic? What are the interventions that we usually do these days? Number one is PRP or platelet-rich plasma, or nowadays again bone marrow concentrate is coming, and many other things which are acting as growth factors that help in rejuvenating the tissue. If you have some cartilage or some tissue left which is inflamed and we need to grow it, or we can say we are putting growth factors. So that is what platelet-rich plasma is. And these are the areas where we can put PRP for various diseases has been told. The most common one, you can say any kind of patellar tendinitis, meniscus, ligament injury, cartilage defects, osteoarthritis. These are the very common. Plantar fasciitis, Achilles tendinitis, will regularly go for this. Again, lateral epicondylitis is very common, as we tell it as tennis elbow. Less is being used in back and the hip injuries, but particularly for the ligament and tendons, we use it very frequently. Next option is radio frequency ablation. Now, radio frequency ablation, what it does is it ablates the nerve that is causing the pain. Ablates doesn't mean that we are cutting away the nerve. If I tell you, it is particularly the grade 2 up to grade 2 neuron injury, so that it can regenerate. If we go for a grade 3 or grade 4 nerve injury, then there will be chances of permanent motor damage or palsy or permanent sensory loss. That is why the radio frequency ablation, what it does, it just temporarily halts the sensory sensation which is causing the pain. It can be used for trigeminal neuralgia, different kinds of facet origin pain, which is very then hip joint pain of unknown origin or of osteoarthritis origin, knee joint, particularly for the genicular nerves, and for the heel pain. Now, for failed back cases, we go for spinal cord stimulator. We'll be discussing it later on. It works as almost like a pacemaker for the heart. Then prolozone therapy. Earlier, we were using very much of a ozone gas along with dextrose and prolotherapy. So nowadays, the use has reduced with the advent of PRP, but it is again used as an adjuvant for adjuvant growth factor. Now, all these procedures that are being done are done under ultrasound guidance or under fluoroscopic guidance. Earlier, all these procedures were being done, many of these joint injections and many others being done blindly, as blind epidural has been given by the anesthesiologist. Myself also, in my post-graduation days, I still remember that I was using epidural injection as a blind technique, and also epidural catheter placement, everything as blindly. But nowadays, everything is precise, and we go for the injections at the target point through ultrasound or through fluoroscope. Now, I won't be going and discussing all the other diseases in detail, but just a giving example. Osteoarthritis knee, various injections are available. Number one is a visco supplement. Number two, as I said, is regenerative therapy with PRP or stem cell or bone marrow aspirate can be given. If not, at last we can go for genicular nerve ablations that particularly supplies the knee, and this is particularly being used in in situations where first of all, I want to say this is not an alternative to surgery or knee replacement surgery. Particularly up to grade 2 or grade 3, you can go for different kind of injections. But those patients in whom you cannot go for a TKR, patients are not ready for surgery, or there are multiple complications with the patient, you can do this for a pain relief. But mind it, this is not going to help you in reducing the mechanical defect. So this is one part for the knee knee pain. This is how we do it. This is done under local anesthesia. Particularly, we put some amount of local anesthesia. Under fluoroscope, we see these are the needles, particularly two needles that are put on the two sides of the lower end of the femur, and one at this point at the tibia. And at these 3 points, you go for a sensory sensation applied for the sensory testing, and you will feel when you put some amount of current, patient will be saying that yes, I am feeling some kind of numbness. So you'll be touching, that means you confirm that you are touching the genicular nerves. So after that, you can go for a radio frequency ablation. Now, this is a heat radio frequency. Also, you can go for a cooled radio frequency that is coming these days, through which you can go for an ablation of this joint. But again, I'll be saying this is not a replacement of knee replacement surgery or an alternative of a knee replacement surgery. Now, this is how we do it. We put it under AP view, then we confirm it in the lateral view, then we go for a lesioning. Now, next very common condition that everybody come across is a frozen shoulder. Now, shoulder pain can be due to various reasons. It can be either because of rotator cuff tendinitis, it can be calcific tendinitis, bicipital tendinitis, shoulder osteoarthritis. Most commonly, what we see is a frozen shoulder or periarthritis shoulder. But many times, young patients may complain of shoulder injury, not able to raise the hand, slap test positive, and patient is young patient, after injury, chances of tendon injury is more. Older patients or diabetic patients, gradual onset of origin, severe pain, not in a particular point, rather a global pain. It is more or less a frozen shoulder, or what we say is a periarthritis shoulder. Again, the treatment protocol, we can go for intra-articular injections. We can go for nerve blocks, suprascapular nerve blocks, as we do in anesthesia practice. Also, we can go for a radiofrequency ablation of the nerve that is supplying this area, so that we can have a painless joint. But again, I'll be telling the treatment is purely physiotherapy. Our role is just to reduce down the pain so that we can go ahead with physiotherapy on a regular basis. This injections or this ablations is not going to help you in gaining back your activity unless until you go for a physiotherapy. Now, this is just an example. If it plays, I'll be showing what we do. We are doing now a hydrodissection. We are putting the needle under fluoroscope or under ultrasound guidance. This is just, I have shown you how we do it under fluoroscope. We put the needle inside the joint. We give some amount of dye to confirm that the needle is inside the joint. Now, this is a patient where the patient was not able to raise the hand. Somehow the video is not playing, but after the procedure, what we do is we put some amount of almost like 30-40 ml of fluid inside the joint so that we can dilate it. And just after the procedures, you'll be seeing that there is full range of motion of the shoulder joint. But we have to do it very precisely. We need to see that there is no ligament injury, there is no other things possible. It is purely periarthritis shoulder. Then only we can go for a hydrodissection of the joint. Now, this is just how we go for the nerve block at the different levels. This is just a fluoroscope image, how we put the needle, then we go for a radiofrequency ablation. The neck pain again, neck pain, there are two categories. Maximum patients, what we see is whether there is a neck pain or whether there is a radiating component or there is a particular muscle pain over this area. This we have to confirm. If particularly there is neck pain which is not radiating down, and various tests are there through which you can see if there is facet loading is causing pain and it is particularly of a facet origin, don't put any kind of press or any kind of collar. You can go for simple exercises or you can go for injections at this point, which is called facet joint injection. If it is positive, then you can go for a facet joint radiofrequency ablation. If not, if there is any chances of disc prolapse that you find from your tests as well as MRI, then you can go for a epidural injection. That is called cervical epidural injections. Now, many patients complain of pain which is vague of very vague origin and not in a particular dermatome. That might be due to fibromyalgia. In those cases, you can go for particularly Botox injection or local anesthesia injection. In simple, if it is Botox is not available, we can go for the injections to confirm that the patient is having fibromyalgia. And the treatment, as we all know, pregabalin, duloxetine, baclofen, these are the 3 years of the approved drugs, as well as we can go for physiotherapy. Now, coming to the most awaited, the topic of the day, that is back pain. If I can say the most common cause of back pain, can anyone tell me what is the most common cause of low back pain in the general population? Anyone?
Mechanical.
Mechanical, but can you just elaborate that if any particular origin, can you, if you can...
Posture.
Is particularly if you see facet origin. The facet origin pain is the most common pain that we come across if you go for the test, rather than what we see is a discogenic pain. Because many a times what we see in our prescriptions in the OPD, patient is having a back pain. Many a times it's written either a low back pain or a mechanical back pain or discogenic pain. These are the, or disc prolapse. This is what, or spondylitis. These are very vague terms that we normally use. But the most common cause is, first is facet origin pain, second SI origin pain, third is the discogenic pain, fourth is the intervertebral disc related pain. So most common is 40 to 45% patient, young patient as well as middle-aged patient complain of pain which is of facet origin that we normally miss, because we tell the patients to go for an X-ray or MRI immediately, and in the MRI 100% out of 100% population will see in 99% there is a disc, and suddenly there will be a bias where we'll be seeing that yes, the patient is having some kind of disc, so we go for that only. Now I'll be just telling you the interventions that we do. Particularly if there is a disc prolapse and it is compressing over the nerve, we can go for a transforaminal nerve root block. That is basically done again under fluoroscope. You confirm the needle position and put some amount of dye along the nerve root. The dye is coming along the nerve root, and you can put some amount of drugs over there. Now again, this is another patient where I was telling you about the sacroiliitis. Sacroiliitis, particularly if the patient is, there is a finger pointing test is positive, Fabler is positive, and you find that the patient is having a sacroiliac joint pain and it's radiating down, not in a particular dermatome. From the clinical test, you confirm that it is the sacroiliac joint is the causative pathology. You can go for intra-articular injections into the sacroiliac joint. Last one that I was telling is a facet joint. Again, first we confirm if there is a facet joint origin, you go for some sorts of tests, that is facet loading. Particularly patient will complain of paramedian pain, and then what we do is we go for an intra-articular injection. This is the facet joint that I'm showing. You go for an intra-articular injections into the facet joint. If more than 50% pain relief is there, you can go for a radiofrequency ablation of the facet nerve, or that is called median branch block. The nerve is coming at this level, that is eye of this Scotty dog. You put the radiofrequency needle over there, and you can do a radiofrequency ablation for the facet pain. Particularly for the tailbone pain, what we do is if there is a tailbone pain, you can go for doses, bath, anti-inflammatory medications and everything. If even after that the patient is suffering from tailbone pain, we go for a ganglion impar block. What we go is we put a 22 gauge needle, we confirm it through a fluoroscope, put some amount of dye, and we go for a ganglion impar injections of xylocaine and some amount of depot steroid. That gives an excellent result in that. Another case is a failed back surgery patient where surgery has already been done. Now, whether fixation has been done or fixation has not been done, there is the imbalance in the facetal loading, and many a time these patients complain of pain because of facet origin or SI origin because of the imbalance in the pressure that is falling upon the facet at the SI joint, as well as if there is adhesions around the nerve, then you have to go for adhesiolysis. For that, we go for epidural injections, and we do mechanical as well as chemical adhesiolysis in those points. For those patients where patient is complaining of pain because of the fracture vertebrae, we can go for cement injections, which is known as vertebroplasty. Normally, we do it for the osteoporotic patients as well as for any kind of malignant metastasis is there and there is vertebral compression. And this procedure, we do it under local anesthesia only, and excellent results we have seen that after the OT only patient will be walking down, and this almost gives a very good result. And if there is some component of leakage, posterior cortex breach is there, in those patients we go for kyphoplasty, where we give a balloon and inside that we put some amount of cement. So this is almost one more invasive procedure. So this is almost that I have already told that if there is sciatica pain or radicular pain, then only we go for this transforaminal root injections. or epidural injections can be given. Then for the herniated disc, if there is herniated disc or a small amount of herniated disc or discogenic pain is there, particularly we can go for a bioplasty or putting some amount of heated rods inside the disc and we can burn it out. So that is bioplasty, that is being done with the same radio frequency ablation technique only, the same machines only. This is how we put the needle inside the disc and we burn those areas or for pain relief. Sacroiliitis, already been told that initially we go for intra-articular injections. If intra-articular injections are giving a good result, then we can go for a radiofrequency ablation of the dorsal branches that is supplying the sacroiliac joint, as well as for better result, we can go for a cooled radiofrequency. And nowadays, again, another thing, cryoprobe is coming through that. Again, cryoablation can also be done for this joint, which gives an excellent result for SI joint origin. Facet, already told, we go for facet joint, this median branch block, and then we go for ablation. Tailbone, already told. Now failed back surgery, adhesive I'll be showing this adhesive. This is a normal picture that when you see. And after putting a dye, you see that there is no dye distribution on this side. You put a X catheter, do a adhesive lysis, put some amount of chemical adhesive lysis. Actually, 10% sodium NaCl is not available. That's why we go with silage and 3% NaCl. We do a adhesive lysis. Then after that, the picture will be coming like the dye is coming down in both the sides. This is the picture of the kyphoplasty that I was. This is vertebroplasty plane, putting the cement. Kyphoplasty, putting a balloon, and in that only we can go for putting the cements. Cancer pain. This is again. This is just for the knowledge that there are many aspects of cancer, and for discussing the cancer pain only. Nowadays, we don't have to rely on the medicines only. Even if there is metastasis or other things, there are patches coming down, and those patches work for 7 days almost. And the same patches can be used for low back pain also, because the patches provide some amount of opioid on a regular basis for almost like 7 days. Buprenorphine patches are coming, excellent for knee pain as well as back pain. The doses for the benign pain is very less, whereas for the cancer pain, we usually go for 10 to 20 microgram per hour doses we could go. And for other cancer pains, we can go for neurolytic blocks that I won't be discussing here. These are just the blocks for cancer pain. I'll skip them. Trigeminal, again, will not be discussing on the trigeminal pain because this is not a part of the discussion. Post-herpetic neuralgia, again, the similar part. There is herpes pain, and we can go for blocking of the same areas. Another, this is just an example of the same one that I was telling you, adhesive lysis, that how we do. There are many other nerve blocks, and nerve blocks that we do, particularly, this is one patient, I'll tell you, the video is not running. This patient is a CRPA patient, once came to me. He had some injury over this elbow, and particularly physiotherapy was not, he was not able to do the physiotherapy. And what we did is, we're putting continuous epidural continuous catheters at the superior brachial plexus, which is giving continuous supply of the drug so that patient will be pain-free and can do the physio. And this we are doing at each and every level. Wherever it is possible, patient is not able to go for some sorts of physio, we are putting the elastomeric pumps are there, and we put a continuous catheter so that patient can go for physio in a longer run. Now, what are the benefits of this minimally invasive pain and spine intervention? The first benefit is, it is done under local anesthesia. So there is no need of a general anesthesia. Patient need not be admitted. It is done under daycare procedures. Patient can walk in and go back. Doesn't have any kind of age bar. It can be done in any age group, particularly with the older age group. Those who are suffering from any kind of cardiac illness, diabetes, or other illness, in them also we can go for this minimally invasive procedures. And it can be repeated n number of times. as there is no side effects. The best example I can give you is 1 year back again, I was bedridden for almost a month because of my acute fissure in L4-5. And there was not a much of a disc prolapse, but because of the fissure, there was excruciating pain. I couldn't even go for physio. And one of my friends did an transforaminal root block for this so that it can reach the epidural space. And I was pain relief. There was excellent pain relief. So in present day, pain relief is the most important thing that anybody wants. So my say will be that instead of relying on the medications and suffering from the side effects of a long-term medications, at particular time, whenever there is a need, you should encourage the patient to go for some sorts of physio and these interventions, because these interventions will let you do the exercises properly and can lead to a proper life. And many times we have seen these interventions can help you in not going for a surgery, or we can just remove the part of the surgery if that is not required. Thank you. This is in a nutshell. Now, because I have completed this early so that we can go for discussion on the particular part, particularly for the back pain component, as I was discussing for the facet, for the SI, for the discogenic pain. These are the three things that we normally see. And another one that I was forgetting was musculoskeletal pain, maybe myofascial pain or fibromyalgia pain. So this is what we normally see. Now, I just want the audience to go for an open discussion so that we can discuss if there is any questions.
Yes, Dr. Sir, there are a lot of questions in the chat box. Before coming to that, I want to have some queries on that. Actually, basically, we are expecting that today discussion will be based on how to select cases for this spine intervention. Suppose one patient is coming to you, you are sitting in the OPD or you are in a clinic.
Okay.
So how do you go? What is the protocol? What is the algorithm? Once the patient reaching to you, how do you differentiate? Yes, this is a pain of discogenic, or this is a pain of from the prolapse disc, or it is from the facet joint. How do you first approach the patient? Coming to a diagnosis, coming to a deciding method of intervention.
Yeah, the first thing that whenever a patient is coming to the OPD, the first thing that we do is a clinical examination and a proper history. Because many a times this history only gives us a clear clue that what sort of pain he or she is suffering from. Suppose the patient is coming and saying that first thing that we ask is whether it is a pure back pain or there is a back pain component along with a radiating pain. Now, if suppose the first thing is patient is having some sorts of back pain with a little amount of radiating pain. Now, examine whether the patient is having the back pain only in the midline back pain or the back pain is a paramedian pain. Now, if there is a midline back pain, the chances are more that the patient is having more of a discogenic pain, which can be either due to prolapse or due to fissure, or it can be due to dehydrated disc or degenerated disc that is causing the pain. Now, if it is a paramedian pain, it can be due to facet origin, it can be due to SI joint origin. Now, if the pain is because of a disc, which is causing only a discogenic pain, either because of any fissure or because of any kind of what I can say is either because of a fissure or a dehydrated disc or degenerated disc, then it is a median only midline pain and radiation is not there. Patient will complain of pain while sitting or doing some kind of exercises. It is aggravated and it is not radiating down. Now, if it is a paramedian pain, suppose facet origin or SI joint origin, then the pain will be radiating down, but it will not be in a particular dermatome. It won't follow any kind of particular dermatome. The pain is usually in SI joint, pain maximum goes to the thigh, maximum to the calf area. Again, the same with the facet joint again. If you are getting a facet or SI joint. What the patient in the history will say, I'm sitting for a long time. When I'm sitting or standing up, I'm having pain. SI or facet can be bilateral, can be unilateral. If it is unilateral, he will be complaining of only one side pain. If it is bilateral, then there will be a circumferential pain. He cannot say show you any particular dermatome or any particular area that I am having pain. He will say that I am having a vague pain. Now, if the patient is having a disc-related pain because of prolapsed disc, then the pain will be radiating down along a particular dermatome, and that can be easily detected without even an MRI that the patient is having a pain in the L4-5, L5-S1 or L3-4, which dermatome he is having pain. So we don't need an MRI in fact, because dermatomes itself can tell us the level of disc prolapse where we are having. If we are going now for any kind of intervention or surgical intervention, then only we go for do an MRI and to confirm again, because these days it is not like you can stamp it. Because of the medical legal issues these days, you have to confirm, stamp your diagnosis from the clinical point of view, what you are getting, along with some exemplary thing like MRI or X-ray that you need to do to establish your judgment that you are giving. And accordingly, you can choose a patient for procedure. Now, these are the three things that cause due to maximum pain, as I was talking in low back pain. Now, when to choose that somebody is needing some kind of intervention? I think everybody is clear how to decide which kind of pain is there. First, whether it is a purely disc or prolapse, only discogenic pain. Second, whether it is because of a prolapsed disc. Third, whether it is because of a facet or SI origin pain. Another one that I was telling is myofascial pain.
Yes. Yes, please.
Another one, if there is a myofascial pain, you might have a trigger point, particularly if there is quadratus lumborum pain or there is particularly pyriformis origin pain, then you will have particular trigger points and the patient, and various tests are there. You people know much better than me what are the tests to be done for this kind of muscles, if they are of muscle origin, that we can diagnose.
Two parts another two parts are there, like elderly lady with the gross osteoporosis, they also complain of back pain. And second is psychogenic pain. How to differentiate these two conditions from the rest of the things?
Yeah, number one, osteoporosis. First thing I want to say, osteoporosis never causes pain. Osteoporosis is purely a painless condition. Whenever osteoporosis causes some kind of fracture, then only it is going to cause pain. It is a very misconception that some sorts of, I have seen many times that patients are being prescribed with only vitamin D, calcium for a longer time. Yes, that is required. I don't say that is not required. That's just to prevent the osteoporosis part. But purely, if I say pure osteoporosis will never cause pain, so in our diagnosis, that is never a part. If that is causing any kind of pain due to fracture, then it is okay. We can go for some kind of treatment according to the fracture site. Now, psychogenic pain, it takes time, sir. Actually, psychogenic pain is very difficult to judge because many patients come with a, but what we have seen that many patients who are psychogenic, they usually suffer from muscular pain, that is particularly fibromyalgia or myofascial pain component is more in them rather than particularly of any pathologic pain like facet or disc. And for me, it takes some time because for 1 to 2 sessions, we need to have some discussions with the patient, and also the clinical examination is a very important part, because in clinical examination you will find that there won't be having particular pain. You say that patient is having SI joint and tell them something else, they will be having pain at another site again. So that is how there is no proven justification or something that can prove that the patient is having psychogenic pain. But at least for with 2-3 sessions, we can know that the patient is not having any kind of pathologic pain. Now, first thing that I do whenever a patient is coming to the OPD is we prescribe the patient normally RICE, that is rest, ice, compression and elevation, and along with that anti-inflammatory medications. Number 1, initially I don't tell the patients for any kind of physiotherapy, at least till the pain subsides. Then we can advise the patient for conservative therapy, for physiotherapy and every exercise. If after a period of almost like 2 to 3 weeks, patient is getting a relief, then fine, we can continue with that only. If again after 2 weeks the patient is not complaining, not getting any kind of relief, and the pain is still persisting, with adequate doses of analgesic, adequate means what I want to say is a maximum dose that we can try. So with maximum doses of the drugs and conservative therapy, if the patient is not getting a relief, then we go for a diagnostic block. Like suppose I am suspecting a patient is having a facet joint pain, what I do is I go for a diagnostic injection, putting some amount of xylocaine only. 1% xylocaine is sufficient to give you a more than 50% pain relief if the patient is having a facet origin or SI origin. Put just 4 ml of xylocaine only inside the joint, patient will be totally pain-free. So we go for a diagnostic block. If the diagnostic blocks are coming positive, then we go for a definitive blocks of radiofrequency ablation if it is required. Now, there are certain red flags that we must consider, that if there is any kind of red flag, then we must send the patient to the neurosurgeon immediately. If there is any kind of tumor you find, if there is any kind of sensory or motor deficit, or an increasing sensory or motor deficit during the treatment, any kind of fracture. So in these cases, send the patient immediately to the neurosurgeon. Otherwise, according to the clinical judgment, we go for the interventions. And in my opinion, as early as you do the interventions, it is always better, because in the acute phase, if you can cure the patient of the pain, it is always better, because once it turned into a chronic pain, then there is neuroplasticity and crossover phenomenon with the other levels. So the pain gradually increases. So it is very difficult to treat that pain if it is a chronic pain. So
some questions in chat box like, sir, in your experience, what is the best option to treat chronic trapezius myofascial pain? Best option to treat chronic trapezius myofascial pain.
Chronic trapezius myofascial pain, you can go for Botox injection, though I'm not using Botox much. What I am doing is I'm going for ultrasound guided local anesthesia blocks along with the physiotherapy. Is the maximum thing I usually do in my practice. And if not, in many cases, if there is associated with some sorts of neck pain, or I find that some sorts of disc related component is available, then we go for epidural injections in them. Otherwise, I go for particularly ultrasound guided injections at the particular sites only. If there is any trigger point, again we go for the trigger point injections. But
any medications you prefer?
Sir?
Any specific medications you prefer? What is your experience on this pregabalin, gabapentin, nortriptyline?
Yes, sir. Medications, I go for baclofen twice a day, particularly for 1 month almost. Along with that, pregabalin is the prescribed for any kind of myofascial pain or fibromyalgia pain. Particularly, 3 drugs are there which are US FDA approved drugs and works very nicely. Number 1 is baclofen, 10 milligram, 20 milligram, almost like BID for a month or 2. Next is a duloxetine. Duloxetine again 20 to 30 milligram twice a day, or you can increase if the patient is compliant. And pregabalin 75 milligram twice a day or 150 milligram twice a day as per the patient compliance. These are the 3 drugs that will give you excellent result. But initially you have to add on some NSAIDs for immediate pain relief. Otherwise, the patient will go away. Maybe naproxen, maybe itracoxib. I personally prefer celecoxib and itracoxib more because of the less of a side effect. So 90 or 120 milligram of itracoxib is much better with the baclofen combination. Initially, I start with baclofen and itracoxib with duloxetine. If not, then I go for the other things.
Okay, one more question is, sir, how long this block works? You are using different type of blocks. So you are using Xylocan or bupivacaine. How long it works? Is it a
Usually
permanent
the drug-
relief?
Yeah,
Yeah.
this drug doesn't have a particular long-term, doesn't act for a longer time, because what we are using is a Xylocan will act for 2 hours. If you are putting some amount of depot steroid, maybe for 3 weeks, maybe for 4 weeks. But our role is not to cure with these injections. There are 2 things we help in. Number 1, we make the patient go for a physiotherapy. Number 2, we break the cycle. The first and the foremost thing that is important in treating a pain patient is breaking the cycle. Unless until you break the cycle, the pain will go on, and it will convert to a chronic pain. At some point, you have to break the cycle. And for that, these kind of blocks are the only thing that is available. Everybody must learn the technique, how to go for different blocks, different kinds of blocks. And this is not very difficult, because nowadays with ultrasound, because earlier we were doing this blocks with in a blind technique, but now when you are doing everything under ultrasound, it becomes very easy. And also with the fluoro guided techniques, you cannot put the drug inside the vessels also, because whenever you put some amount of dye, they will be going where the dye is going, you can see it clearly. So these drugs will give you an immediate result, immediate pain relief, so that you can let the patient do a physiotherapy and break the cycle.
In severe lumbar canal stenosis, not willing for surgery without motor and sensor deficit, but neurogenic claudication at 100 meter, can we go for epidural injection?
Yeah, absolutely. We can go for epidural injections, but we have to look for the epi diameter. If it is less than a critical stenosis, like if it is less than 7 or 6, then it is difficult to say that it will work. It may work immediately, but after 10 days, the patient will say that I'm having severe claudication again, which is not getting resolved. But according to the AP diameter, we can choose. If there is a midline shift in the disc and middle line disc and compressing upon the spinal cord, AP diameter is less than 6, it is better not to touch and send the patient to the neurosurgeon or the spine surgeon. But again, we can try. If you want, we can try. There is no harm in trying these patients. But usually in my practice, I don't touch the patient if it is less than 7 or 8.
Any interventional procedure for pancreatitis related severe pain, not responding to opioids? Do you have any experience on managing pancreatic pain?
Regularly, what we are doing, pancreas related pain are of 2 types, particularly if it is chronic pancreatitis of benign origin or it is a malignant CA pancreas. In both the cases, we go for a celiac plexus block plus splanchnic plexus radiofrequency ablation. In celiac plexus block, what we do is we put 15 to 20 ml of alcohol. With alcohol, 100% or 70% alcohol, we try to burn the nerve celiac plexus, but the alcohol lasts for 6 months. So it won't give a longer lasting effect. That is why, again, we go for a D11 and D12 radiofrequency ablation of the splanchnic nerves. This gives a long-term pain relief, particularly for those who are suffering from chronic pancreatitis. Yes.
Any medical or interventional treatment for proctalgia tubus?
You can go for this ganglion impar injection, but particularly I have never used it, but this can be used for anything below the L5 level, particularly of the pelvic cavity, anything. of the woman or main origin, we can go for ganglion impar injection that works. You can try, but I don't have any personal experience for this kind of patients.
Is there any contraindication of using alcohol for acute pancreatitis? I mean,
There is no
injection?
side effect with alcohol for acute pancreatitis. Sorry, for acute pancreatitis, yes.
Yeah.
Because it's a benign origin pain, we try to do it with local anesthesia and steroids initially. Otherwise, if it is possible to go for radiofrequency ablation, we don't use alcohol particularly for the benign conditions initially. But if it is refractory and not working to, not responding to anything, then we can use alcohol. There is no contraindication that you cannot use alcohol for chronic pancreatitis or acute pancreatitis. Usually we don't, but if it is refractory and chronic origin, then we may.
Okay. Probably there are no more questions in the chat box. In that situation, we'll have to close the session. There is no more questions in the chat box for you. So thank you, Professor Dr. Shovan Rath, for a good clinical discussion. Besides your problem with presenting the slides, of course, we are a little bit debated. We can understand the problem.
Really sorry for the this mishap in that I lost my slides, but I have tried.
But anyway, the discussion was very nice, especially how to approach a back pain patient OPD and how to decide different procedures.
Just put a last word before ending that for this only very soon I'm starting up a fellowship course for those who will be interested for at least for 7 days, where those who want to have a practice on the mannequins as well as the patients, both the ultrasound as well as the fluoroscope guided procedures, how they are being done, how we judge a patient, starting from the OPDs till the OT. So I'll welcome all from the. So anybody interested can join.
Thank you, Dr. Shovan. You have accepted our invitation and presented a beautiful talk, especially clinical ways. Really, we are thankful to you, and I must thank all the participants, to those who have joined this webinar. Hopefully, you all have definitely gained some knowledge regarding this, how to decide intervention in different types of painful conditions. And I also would like to thank all my colleagues of Department of PMR, SVNIRTAR, and all the office bearers of Odisha Association PMR, as well as the PR team of IAPMR and all office bearers of IAPMR. Thank you very much for supporting us, for organizing this type of webinar. I hope this type of webinar will certainly helpful for all the young physiatrists. Thank you, Dr. Shovan. Thank you, everybody, for joining us. Thank you. Good night.